Hi, everyone. My name is Sadie McGuire, and I am an occupational therapy capstone student here at Children's Hospital New Orleans. And today we're going to be talking about different strategies for kids who have difficulties with feeding. And this will all be from an OT standpoint. Um, OT and speech sometimes do overlap with handling certain feeding concerns, but within feeding, we each have our specialties and our areas that we are skilled and equipped to handle. So if your question isn't answered in these slides, you can ask your OT or you can always ask your speech therapist as well. I also want to say that at the end of the video, there will be a QR code for a post survey that really helps me out as I'm running this project and program to see how helpful these modules are for you guys and how y'all feel about them. You can either fill that out online or you can ask one of your therapists when you come into the clinic for a hard copy to fill out in the lobby or wherever and turn that back in. And that is very much appreciated. So without further ado, we will get right into it. Before we start talking about issues with feeding and how to work with kids with difficulty feeding, I wanted to touch on the development of feeding participation really quickly because understanding the continuum of how feeding develops from baby to adult can be helpful in understanding where some of the hangups are and when your child might be having an issue um, related to development versus a sensory issue, as well as making sure that your expectations for your child align with what's realistic and reasonable for their age. So, when your child is an infant, feeding is either obviously through bottle or breast. And it's a time of bonding and warmth and comfort because they're snuggled with you. It's really important in developing a secure attachment style. And as they're feeding, they're doing it with a suck, swallow, breathe rhythm. Um, and that's a reflex that children should be born with. During the infant phase, they also have a reflexive phasic bite, which is where if you put something in their mouth, they will just bite down and not really be able to release because it's a reflex and they're not trying to bite or chew. Once they're between 7 and 24 months, this is a really important time for the development of feeding, as you can see, because it is such a long time span. And so many things are happening in your child's life between 7 months and 2 years old. Um, Finger feeding can start to develop once your child's trunk control develops. So once they're able to sit up and hold themselves up, control their body more, then they can start finger feeding with their hands and getting that nice pincer grasp, getting some puffs in their mouth is usually a favorite first finger food. Once they are able to control their oral motor skills a little better, so their bite, how their tongue is managing the food in their mouth, they'll start to explore different textures and the sensory qualities of foods. This is where kind of the very beginnings of food preferences and food exposure develop. Um, and the type of chew, we often just think of chewing as chewing, but there is a development within chewing. At first, it's just lateral jaw movements where the jaw is just moving in one direction, kind of chomping. Then lip and tongue control also develop separately because you have to manage the food. You have to be able to close your lips around a spoon or a fork, hold the food in your mouth. Your tongue has to move all around to make sure everything is chewed and then push it down back down your throat. Um, and if you are unable to do those skills, it makes it really hard to manage more complicated foods. And we'll talk about what complicated foods means in just a little bit. And by two, they develop rotary chewing, which is the more adult form of chewing, which two is also when they should be a full mealtime participant. So they should be able to kind of manage their utensils, tolerate all textures, chew their own food. Obviously, we're not expecting a 2-year-old to be able to sit there and use a knife and fork to cut up a steak, but they should be able to mostly manage their utensils themselves. This is kind of the development of when you can introduce different types of foods because as we were talking about in the last slide, the development of the oral motor skills to manage certain types and textures of foods doesn't develop until later. So you don't want to introduce those foods until later because it's not safe for your child. At 6 months, you can start to introduce thin baby foods and slowly increase the thickness with a goal towards progressing to soft mashed table foods like mashed bananas and things like that. By 8 months, um, and I just want to pause here and say when I say by 6 months or by 8 months, this is kind of an average of a developmental milestone. Like usually around 6 months, you can start introducing these things. That's also dependent on your child and if they have those prerequisite skills to manage these types of foods. So you need to be able to look at your child and understand if they are ready to progress to the next texture or type of food. Just because they're 6 months old doesn't mean that they're necessarily ready for thin baby foods. This is just kind of an average overview. So I wanted to put that in there real quick before we continue. But with 8 months, typically you can start to introduce hard munchables. So these are long, not necessarily long, but large pieces of food that can't be fit all the way in their mouths, such as carrots, frozen veggie sticks. They're hard. That's the key why they're frozen. Dutch pretzels, things that are really hard that they can hold in their hand and kind of gnaw on, kind of like Bugs Bunny with a carrot, only they don't have teeth yet, so they're not able to take a bite of it. And this helps them to start developing the oral motor skills. They're not supposed to be eating these foods, but it can help them to learn what it feels like to move their jaw up and down on a food, have their tongue come out and touch it, different things like that. That's all part of promoting that skill development for later. So you always need to be supervising them 100% of the time, really anytime they're eating when they're small, but with hard munchables, it's just to encourage skill development. By 11 months, you can start doing single texture soft mechanical foods. So these are foods that easily break apart in the mouth. That's what mechanical kind of indicates, like muffins, scrambled eggs, white bread with no crust. If you think about putting these items in your mouth, you could kind of smash them up without using any teeth or biting. By 12 months or a year, you can progress to more soft mechanical foods. These have a little more substance and the texture is mixed: mac and cheese, french fries, spaghetti, peas, things like that. Nothing hard or crunchy, and they're still pretty easy to smash up in your mouth, but it's a little more complicated if you think about mac and cheese versus scrambled eggs. There's a little bit more to manage when you're eating a bite of that. Then soft table foods can be introduced. Um, when this can be a lot of different things, but when you're introducing soft table foods to your child, you really want to make sure that it's an appropriate size and texture for your child to manage. And you also want to be sure that you're offering a variety of flavors and textures because this is the time when your child learns to accept a lot of different textures and a lot of different tastes. And it can be a time when picky eating starts to emerge, and you want to really be sure that you're offering a wide variety of things for your child to have exposure to. Um, by 15 to 18 months, that's when we can progress to the hard mechanicals like crunchy things, chips, crackers, veggies, and they're going to continue to explore these types of foods and refine their skills to be able to manage this more challenging texture. I just want to reiterate also that the offered food should always match the current skill level of your child, and going too quickly isn't going to help them get those skills faster. It just increases the risk of choking. And if they have a traumatic almost choking event, hopefully it's not an actual choking event, but that scare can create a strong negative memory of that food, which you really don't want if you're trying to avoid picky eating or limited food preferences, things like that in the future. So there's a lot of factors that influence successful feeding, and which is why feeding therapy isn't always cut and dry. And there's a lot of things that go into it in trying to determine where the issue lies. Um, if your child has dysphagia and difficulty swallowing food, I would encourage you to talk with your SLP or even your OT if you're in feeding therapy about specific concerns related to dysphagia, just because that can be such a safety concern when they're not able to swallow food. So some medical history factors that influence the feeding ability are different medications that your child's taking that might increase their appetite or decrease their appetite. Different diagnoses come with different symptoms and signs that make it difficult to eat or might affect the appetite one way or the other. If your child is really high tone or low tone, that can make it really hard to develop um, complex and skilled oral motor skills. Like when I say oral motor skills, I'm talking about moving your tongue around and your lips and chewing and things like that. There really is a lot of motor skill happening in your mouth when you chew. Also, tethered oral tissues like tongue ties, cheek ties, lip ties, those are often underdiagnosed, um, and they can really impact feeding and make it difficult for your child to accept different types of foods and textures and also learn to manage them in their mouth because they're not able to manage them and then they know they aren't, and so they will not accept those. Also, the environment can play a large role in how feeding goes. If there's lots of distractions around, if your child is not regulated, if you think that your child has issues with regulation, I would encourage you to watch the sensory processing lecture, um, also posted on this YouTube channel. If your child has visual deficits and they're not able to see the contrast of the food on their plate, they can't really see what the food is, what it looks like, they're not really going to want to interact with it. Similarly, sensory deficits, if they have differences in how they interpret sensation, food might not be enjoyable to them, or it might be kind of scary. Also, endurance and positioning. How are they sitting at the table? Are they slouched? Is it hard for them to sit up and they're spending all of their energy managing their body and they don't have any time or mental space to worry about eating? Also, are they alone or with their friends? That can impact it as well, sometimes positively or sometimes negatively. If they're with peers, they might be encouraged to eat and be like their friends, or they might be distracted. With positioning, making sure that your child is really supported and sitting upright is super important for promoting their independence, but also their safety with chewing and swallowing. If they're slouched, the risk for choking gets a lot greater. So if you aren't able to have your child be sitting with um, upright head, upright posture, 90-degree hips, 90-degree knees, 90-degree feet supported. Feet supported is one that's often overlooked. Then you might want to consider using a high chair or booster seat so that they're able to successfully interact with their food. Something to consider is you can't successfully move your hands and your arms well unless your trunk is secure and supported. If your trunk is really unstable, then you're not going to be able to use those fine motor skills required for successful eating. Um, so don't neglect the positioning aspect of feeding. If your child has musculoskeletal deficits, CP, things like that that make feeding difficult from a managing the utensil standpoint, there are a lot of different adaptive equipment options that are available for feeding. The silicone universal cuff is good if grasping the utensil is difficult, as well as a built-up handle. And you can see on the side next to built-up handles or built-up utensils, some spoons and forks are offered curved, so it's a lot easier if your child doesn't have the range of motion in their arm to bring the spoon to mouth. Textured spoons are good for kids with sensory differences or really low tone in their mouth, to kind of activate those taste buds and, well, not taste buds, nerves, and get those muscles moving a little better. At the bottom is suction cup bowls. They also make suction cup plates if the spilling and pushing around and controlling the actual plate or vessel is an issue. And then there's also small spoons. If there's poor lip closure, there's spoons that are specifically designed for that issue. So one of the issues that can impact successful feeding is hypersensitivity, which means that your child is just receiving too much input from the world around them, from all of their sensory systems, and they're not able to tune out or disregard the things that don't matter or that they need to ignore. And when this happens in the mouth, it can be because they were already hypersensitive as a person. If they have autism, they might be hypersensitive to everything: sound, sight, smells, tactile touch, things like that. But they can also just be hypersensitive in the mouth. For example, if they have had a tube placement from the time that they were little or a long period of time, sometimes they are hypersensitive because they haven't had a lot of things in their mouth, experimenting and just learning about those textures. And so everything feels like it's too much. If your child is hypersensitive, they might be gagging, coughing, trying to get it out of their mouth. They don't like it. They might spit. They also might hold the food in their mouth and pocket it and keep it in their cheeks or keep it in their mouth because they don't want to interact with it at all. And so they're just keeping it there because that's easier than chewing it up and dealing with it with their tongue. They also might resist certain textures, temperatures, or tastes. If they feel that a certain texture is too much for them, they will tend to avoid it. They also might be averse to brushing teeth, messy play, getting dirty in the mud, or actually touching the food with fingers. And this is more if they have hypersensitivity all over, not just in their mouth. Um, with kids who are hypersensitive, they may view eating as a negative experience and they're not enjoying the process of eating. They're not doing it as much. So they have not developed as skilled oral motor skills. And it makes those more advanced mixed textures and crunchy items and things like that difficult. Obviously, this could result in poor nutrition and weight gain if they're not eating. They're not getting the nutrition they need to grow and they're not gaining weight. On the other end of the spectrum is hyposensitivity. This is super low um, sensitivity. They are not really, for lack of a better term, feeling the sensory input through their mouths. Sometimes, for example, this could be with autism. If they are low registering, again, might be good to go check out the sensory processing video. If they're low registering, they're not noticing those sensory inputs. Also, diagnoses like Down syndrome with low tone might present with a little bit of hyposensitivity as well. These kids tend to enjoy strong flavors and mixed textures because it's just more stimulation. So it's giving their body a little something extra for them to pick up on. They may make a mess when eating and they leave the food all over their faces because they don't know that it's there and they don't have the skills to kind of manage the food based on the feedback that their body should be receiving. They also might pocket just because they don't know it's in there or they don't have the skills to manage it. They can take large bites, might not chew enough, or they are at risk for choking because they are taking such large bites. To manage this, you can provide input to kind of wake up the mouth, which the strong flavors and mixed textures kind of helps with. Throughout the day, you can offer things to chew on with varied textures and flavors, like different types of snacks or chewy tubes, Z vibes, things like that. And when kids who are hyposensitive are eating, you really want to monitor closely for choking risk just because they're not able to manage the correct bite and size. So if you have what's usually called a picky eater, they might be in feeding therapy with an occupational therapist or a speech therapist. Feeding therapy is a play-based approach designed to address the regulation, sensitivities, and those restrictive preferences, all while creating positive attitudes around food. We don't want to create any negative experiences that might further limit the preferences of your child. And it's kind of a partnership. We really focus on making sure that the things that we are working on in therapy can be carried over at home. And when they are, they can help your child to begin to accept new foods, hopefully. Um, when your child is at therapy, at first during feeding therapy, we will focus only on exploring new foods, any regulation issues, address things like that, and sensitivities so that they're able to explore new foods. And then when you're at home, the meals will focus on consuming enough volume of food and nutrients to sufficiently nourish your child. And then exposure is a secondary goal. You're not trying to constantly get them to try new foods, try new foods, try new foods at home at first. And we'll talk more about that later. With feeding therapy, consistency is key. I want to emphasize that because it's so important that if your child says they don't like something, they're not going to eat something, they're averse to it and have a really negative reaction, they might not want to engage with that food for the first 12 times you offer it, but you just have to keep trying. And it's really important that if you establish a routine, you keep to the routine. If you offer a food, you offer it multiple times before you say no, they're just not going to eat that food. So, one of the kind of principles that we use to guide feeding therapy is we have this continuum of the steps to eating. And if your child won't eat a food because they are really averse to it due to sensory issues or a negative experience, things like that, we encourage through play all interactions with the food because it helps your child get an understanding of what that food looks like, what it feels like, what it tastes like, and eventually, hopefully, they will put it in their mouth and eat it. So, at first, your child just needs to be able to tolerate that new food being on their plate. You can say you don't have to eat it, but it's got to stay on your plate. And some kids, even step one is really hard. They cannot stand it being on their plate because they're so averse to it. The second step is interacting with it. They don't have to touch it with their hand. That's later on, as you can see, but they might use a fork to kind of push it around or use another piece of food like a pretzel and poke at it or something like that. And they're interacting with it. They're not just ignoring it. They're saying, okay, I'll touch it with this other thing, but I'll touch it. The third part is smelling it. So if the food has a really strong odor, they don't become upset if you can smell it when you walk into the room and you're like, oh, it smells like eggs in here. And your child is okay with that, even though they don't prefer eggs. I'm just using eggs as the example because it's on the picture. Um, we also encourage children when they're playing with their food to pick it up and sniff it and say, what does that smell like? It smells spicy to me. It smells sweet. And talk about what it smells like. If they're able to bring it up to their face and smell it, or bring their head down to the plate if they're not ready to touch it yet, that is a step along the continuum. The next step is actually touching it with their hands, their finger, giving it a little kiss on the with their lips, say, and then put it down. Maybe even touch it to their teeth or the tip of their tongue. All of that is getting them to familiarize with the texture of it, with the feel of it, and it just has to be a brief touch. Um, but they're starting to accept it more. I'm losing my train of thought, but like more closer to the act of actually putting it in your mouth and eating it. The next one is taste. And they don't have to actually go from touching it to putting it in their mouth and eating it. They can just taste it and kind of experiment with how it's going to taste with a lick. They can bite and spit it out. They can hold it in the mouth for a few seconds before spitting it out. Something we do with kids who have progressed this far along the continuum, where they are able to put it in their mouth and let it touch their tongue so they can taste it without an outburst, is the bite and blow method, where we say, okay, you don't have to eat any more of this, but you need to put it in your mouth to spit it out into the trash can. Maybe for if there's a piece of bread, for an example, and they've eaten one bite of bread and they said, it was so gross, I can't do it, but they can tolerate it being in their mouth, then you might try, okay, well, we're gonna spit our bread into the trash can. You can't throw it in the trash can with your hands, just throw it with your mouth. And it's called the bite and blow method. And some kids honestly think it's kind of fun. Um, as long as you watch your child's cues and know when they've kind of been pushed as far as they can be pushed before they create a really strong negative experience with that food. If they're gagging and just can't go on, maybe just let them throw the rest of the food away. And then finally, the last step is obviously eating, biting, chewing, or swallowing some of it or all of it, hopefully. But it likely won't be all of it, especially at first. This is a handout that has the progression of the steps to eating. And at the end of the video, there will be a link. If you've seen any of these videos before, you know the drill. There will be a link to a document that has some helpful tips, and this picture is included in there. But I just wanted to point it out because I think it can be helpful to reference when you're working on progressing along the continuum at home. Another thing to consider is create a positive mealtime environment. Don't put a lot of pressure on your child to eat at mealtimes. Don't say, "Oh my gosh, you're eating, you're eating, you're eating. Can you please eat this? Can you please eat this?" Because that puts pressure on the child and they're going to kind of um, back away from that pressure and it might turn them off of eating that food even more. Also, consider how much time is allotted for a relaxing meal. They're not rushed, they're able to explore their food and kind of figure out what's going on with it, what they like, what they don't like, what they feel comfortable with. And if they have only a small amount of time and you're rushing them, which I understand that it's not always possible to just provide unlimited amounts of time for a meal, but if they don't have enough time for a relaxing meal, it can make it where they just won't try the food. Also, is the environment relaxing and conducive to a regulated child? Not just how much time is there, but are they actually able to relax and feel comfortable in the environment? Are they able to be regulated? Is there a TV playing? A lot of times the TV is very dysregulating, even though you might not realize it. It's a distraction. It is a stimulant. It's keeping your child kind of in a little overstimulated, typically state, and it's just not conducive to focusing, relaxing, and centering on enjoying the meal with the family. Also, is there at least one preferred food available for your child to eat? We don't present a ton of foods that we know they hate all at once. We might try a couple of non preferred foods and one or two preferred foods so that they do have something safe to eat at the meal with the family. With feeding therapy, mealtime at home is super important, and we've talked about some of these a little bit. At first, adequate nutrition is the primary goal of mealtime, and exploration of foods is secondary. So we're going to kind of start from there. At first, in therapy, they'll work on exploring their foods, but at home, just make sure that they're getting adequate nutrition. Um, and once feeding therapy is a little bit more established, you can start to initiate some of these techniques that we've talked about. Um, Everyone in the family, if possible, should sit at the table and everyone should take a small amount of all foods offered. This is kind of establishing the routine. We all sit at the table, we all eat our food, including you, child, including mom, including dad, including sister, and we're all going to take a small amount of the food. We're all going to try everything. Like I said, be sure to include at least one preferred food. When you are sitting with your child, you're their role model. So try all the foods offered. Don't make your child the focus of the meal. Don't sit there with nothing on your plate and just stare at them and watch them and say, eat this, eat this. That's kind of goes back to the putting too much pressure on your child. Just be relaxed. Chat with your spouse or with your children or with a friend or with if it's just you and your child, just chat with them about their day. Kind of like when you go out to eat with friends, it's fun, it's relaxing, you're catching up on your day, it's a social time, but you're also eating your food and you're demonstrating that for your child. If your child interacts with food that they typically don't, you can praise interactions with that food of any kind. If they're touching it, if they're smelling it, you can say, "Wow, I noticed that you really touched your food, and what did it feel like? Did it feel soft or hard?" Things like that can be really helpful. Once routines are established in the household and also in feeding therapy, you can start to encourage more exploration of the food, like we mentioned earlier. You can try alternating bites of preferred and non-preferred food. So if they won't eat peas, but their preferred food is chicken nuggets, you can say, before we try any more chicken nuggets, let's have just two peas. Um, and you're never forcing them. You're never, um, like I said, putting so much pressure on them to eat those peas, but it's just encouraging them. You can also discuss what it tastes like. Ooh, it's very salty. I like that. What do you think that it tastes like? Have you ever had anything that tastes like this? And that's kind of just getting them to think about the experiences that they're having with that food. Again, you want to be very mindful of creating negative experiences around food. And I want to emphasize that we need to learn how to eat before we learn about manners. So we want to encourage all interactions with food, even if it's messy, if they're touching their fingers all up in the food, they're not wiping their hands on their napkin, they're not using their fork. And it might be really hard to let that happen because it might make a mess. But at this point, it is more important that your child learns how to eat. And then once they've started to accept more foods, you can start to enforce more manners and things like that. When you're managing feeding behaviors at home, it might be helpful to use a reward chart. They can get a sticker every time they try new food, and if they get 10 stickers, they might get to pick out a new toy or have some screen time, something like that. Um, and again, be aware of the pressure you might be unconsciously putting on trying new foods. You might not even realize it because you're so excited that they're trying new foods and you just want them to eat new foods so bad. Um, but sometimes while praising can be beneficial, just know your child, and it might be better to remain nonchalant because of the pressure that it might put on to say, "Oh my gosh, you tried it! I'm so excited for you." It might be better just to remain cool and say, "Oh, great job! Moving on." Um, Also, your mealtime should be a routine. The child should know what to expect. They know that everyone sits down and no one is immune. Everyone gets to participate in it. Everyone takes food, everyone eats the food, everyone maybe helps clean up. But the point is that your child has this time of day where they know what is expected of them. They know that everyone's going to sit down and they are all expected to eat and participate in the mealtime together. Kind of going off of this, having meals at a scheduled time every day helps your child to know what to expect and give enough warning. You could say, in 5 minutes, we're going to go wash hands for dinner. And that lets them kind of bring their mind around to the fact that something that they do not enjoy is coming. Um, Also, consider limiting snacks and juices throughout the day so that your child is actually hungry at mealtime. Obviously, offer water whenever they want, but sometimes juices, all of the sugar can create highs and lows of energy and crashing and mess with appetite cycles, things like that. If your child is very dysregulated or seems to be bouncing all over the place, um, then you could try regulation activities before the meal. So that might look like scheduling physical activities right before meal times. If they have a sports event or play date, it might be good to, if you can. I know sports events, you don't really choose to schedule the times, but having the physical activities right before meal times could be helpful. Um, Different activities like blowing bubbles, marching, leapfrog, trampoline, doing all of those things before dinner. And then while you're at dinner, you could use a Z Vibe, which is that kind of stick thing at the top of the screen with all of the different attachments. It's just creates a little vibration that can help to desensitize the mouth for certain things, or it can help to increase um, the input offered if your child is hyposensitive. If they sit on a peanut ball in place of a chair, or you could put a wobble seat in the chair. The wobble seat is that green thing at the top, and it kind of provides input and helps to regulate while your child is sitting. If they have the wiggles, you can also have them kick a TheraBand tied around the chair leg, like in this picture, and that can give some proprioceptive input to kind of help regulate while they're expected to sit at the table and join in the meal. Another thing I wanted to discuss is the nutrition. While it's super hard to strike a balance between just giving your child whatever they might want to eat just so they'll have eaten something, it is so important to give them proper nutrition because they are growing and developing, and without the proper nutrition, they will not be able to do that appropriately. Um, as parents and caregivers, you're responsible for providing nutritious, appropriately sized foods for your child and having that as an option and offering it to them and saying, "No, I'm not going to give you more sugary snacks. Here's your options for snacks." Or when you're providing different non preferred foods to try, make sure that they're nutritious so that if they learn to prefer them and start to accept them, they are getting protein and healthy fats and whole grains. Your child's responsible for what they put in their mouth and eat, but it's up to you to provide the healthy options for them rather than non nutritious choices just because that's all that they'll eat at the time. Also, always practice safe eating at all meal times. You always want to supervise your child. You never want to give them something that is too complicated for them to chew and swallow because that is a choking hazard. And if you have any concerns, you can always consult with your OT or SLP about any issues or questions that you may have. The top QR code is a helpful link document where it goes into the developmental continuum, lots of different tips for meal times at home if you want to know more about how to structure your mealtime and what that might look like. And at the bottom QR code, that is a post survey. And please, 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 please do not forget to take that. If you would like a hard copy, then you can just ask at the clinic. And thank you guys so much. Don't forget to let your OT know if you have any questions.